We did a recent study where we analyzed the outcomes of patients who had received immune checkpoint-based treatments, so PD-1 or PD-L1 inhibitors or CTLA-4 inhibitors, either as single agents, in some trials we have in MDS, or as combinations in some trials we have in AML. And we studied these patients who went to allogeneic stem cell transplant, and to see if, one, this was a tolerable approach, two, what was the incidence of post-transplant GVHD, VOD, hyperfebrile reactions, and three, if there was actually an impact on efficacy and outcomes post-transplant. And we presented this data as an oral presentation by Dr. Oran, one of our stem cell transplant colleagues, at the recent ASH meeting a couple of months ago. What was actually quite surprising and not what we intuitively expected to see was the overall incidence of grade 3-4 GVHD was similar or slightly increased with the immune checkpoint. We expected that part, but it really was dependent on what the type of post-transplant GVHD prophylaxis was. So we had a group of patients who got Cytoxan as a post-transplant GVHD prophylaxis, and others that got non-Cytoxan-based GVHD prophylaxis. And there was a stark difference in the GVHD rates in the people who got Cytoxan, who had almost zero GVHD for grade 3 and 4, versus those who got other non-Cytoxan-based treatments. In fact, the people who had immune checkpoint treatment before transplant and got Cytoxan post-transplant had less GVHD than our historical controls who had got transplant without the immune checkpoint. So in our practice now, Dr. Champlin, who's the head of our transplant group, is actually using post-transplant Cytoxan not just for AML-MDS, but even for patients with myeloma, lymphoma, who have had an immune checkpoint-based exposure in the past, because we really think that somehow this is abrogating any GVHD. The second thing that we saw is that it may actually even have some impact on the 6 months and 1 year EFS and OS. What we saw was actually the event-free survival and overall survival in the people who had had the checkpoint inhibitor and then got allogeneic stem cell transplant was actually better in the people who had post-transplant Cytoxan than what we have seen in our historical controls. So these are small numbers, we don't know for sure, but it definitely seems that it is safe to take people who have had a checkpoint inhibitor transplant, but using post-transplant Cytoxan probably gives you the best safety threshold. And we need to follow up longer and try to understand immunologically why this group actually may have some survival benefit. And that was the topic that we published on recently, because there's a lot of questions about whether these people can go to transplant or not. And we think at this time, the transplant decision should be made solely on the usual transplant factors, the ELN, the cytogenetics, and not based on whether or not they've received a immune checkpoint treatment.